Welcome, everybody. Thank you for being here. I'm Scott Frank, Director of the Master of Public Health Program here at CASE, also Director of the Shaker Heights Health Department, and a family physician. So I'm very pleased both to be here and that you all are here. I recognize most, but not all of you. Welcome. There is a renewed energy about trying to find functional ways in which public health and primary care can partner to the same degree that we share values. It's been, as Kurt knows, a passion of mine really since I started getting more involved in public health to find ways to functionally tie public health and primary care together, and Paul is very much doing those kinds of things, very much looking forward to his talk today. I'm going to turn the microphone over to Kurt to introduce Paul.
I'm Kurt Stange. I'm in the Department of Family Medicine and Community Health here, and also in epidemiology and biostatistics. We're going to use this, by the way, this microphone as a talking stick. So I think Paul's going to be interacting with the audience, and we are recording this. So help us if you want to say something. Raise your hand, and I'll keep an eye out and pass the microphone around. I'm delighted to have Paul Thomas here with us. We actually just flew in a couple hours ago from New Orleans, where we did a bunch of things at the North American Primary Care Research Group meeting, but one of them was to do an international workshop with people that are trying to integrate primary care and public health. And simultaneously with our 3-hour workshop was another workshop on people that were trying to reinvent general practice and primary care. And interestingly, people in both those groups kind of regretted that these meetings were at the same time, and so a group got a group of both those groups together, and some things are going to be happening to try to keep that work going forward. I met Paul actually I think 12 years ago actually at this same group's meeting, and found that we shared a lot of common interests, and I've had a chance since then to witness the work that he's done in the UK. I've been over there a number of times. Paul does a lot of work at the community healthcare interface. He grounds that work in general practice. So he started doing work as a facilitator for practice change in Liverpool 20-some years ago, when Liverpool is a very socially deprived area. And the work that he did there started with trying to improve general practice, and he rapidly found that to improve general practice, he couldn't work within the 4 walls of a clinical operation, that he really needed to do more work in the community. And even to work on what happened in those offices, he had to do things like they needed properly trained nurses, so we worked with the local technical college to start that. There were rampant problems with gangs, and started a group that was working to have things for unemployed youth, to have some positive things to do. So we did phenomenal work there, then moved to London, and in London I was able to witness the work that he's been doing, and I think that's the work he's going to tell us more about. Paul's approach really is a whole systems approach, so starting with one part of a system, but then thinking who needs to be at the table, getting groups at the table to try to solve the health problems of a community. A couple of things I'll pass around while he's talking. One is a copy of Paul's book, Integrating Primary Healthcare, Leading, Managing, Facilitating. When this book first came out about 6 years ago, I had one at home, and I didn't get to read it when it first came, and my wife, who's a pathologist, was hogging it. And I said, Anne, why are you reading this book? It's about primary health care and public health. And she said, no, it's about leadership. It's very interesting. So I finally got to read it, and it's a very interesting book. And then the other thing I'll pass around are some sheets on an initiative called Promoting Health Across Boundaries, that's looking at the work that we do crossing institutions, organizations, disciplines, ways of thinking. There's a one-pager on that. At the back of the one-pagers are ways you can share your stories of boundary-spanning work that you might be doing. And I think Paul will tell about some of the work of case studies we're trying to do of people that are doing boundary-spanning work that promotes health. And then there's a sign-up sheet if you'd like to get future emails about events like this. So without further ado, I'll turn it over to Paul Thomas.
Thank you very much, Kurt, and thank you very much for inviting me here. It's a real pleasure to be here again. Some years since I've been here, and I've really got great friends in Cleveland. I just want to pick up on something that Kurt said about what happened at NAPCRAG. There is, it seems, a growing international recognition that some of this stuff is very difficult. And in fact, the result of the 2 workshops that Kurt described was a meeting the following day that Larry Green sponsored, at which a number of us made a commitment to develop over the next 12 months 2 streams of discussion. And I want to invite you to get involved in these streams of discussion because they could be of great importance internationally about how we think about future healthcare systems. The first stream is, what is generalism? I may say a little bit more about that as I get going, but what is generalism these days? Why does it matter? Does it have a place in the future? What kind of place to have? But secondly, what environment nourishes it? If this is so important, what infrastructure, what environment nourishes and develops it? And I think very quickly as we get into that debate, you recognize that public health is central to that. So I'm aware that our public health and primary care context in the UK and here are very different. So I've got stuff to show you about what we're doing, but I really want to spend quite a bit of time on the first 2 slides, which are not about what we're doing, but they're statements. And I want to, having said what they are, invite you to contribute to this discussion about these things, because if they're correct, they've got major implications for how we think about public health primary care partnerships anywhere, irrespective of the context. So I'm going to say what those 2 things are and then hear a little bit about who's in the room and see if that can spark a discussion to check out whether or not this is something valuable to shout about or not. So I want to put to you that primary care and public health need a shared developmental space. Because if they don't, a lot of my work is wrong-headed. But if they do, it's got major implications for strategy. I'm going to go through these and I'm going to come back to them. So public health and primary care think differently about health is improved. Long-term partnerships for health improvement require long-term opportunities to appreciate what each can contribute. But having opportunities to find out about people isn't enough. You need a sequence of shared projects to build trusted relationships across public health primary care divide, but actually many other organisational and ideological boundaries. And the moment you get that far, you have to describe a shared developmental space, a community, and probably a geographical area. So that's my first contention. The second is that having a shared geographical area will only reproduce the Tower of Babel, everyone shouting at each other and misunderstanding each other. It won't actually produce anything valuable. Sustainably sustainable development within communities required mechanisms that facilitate ongoing inter-organisational learning and coordinated improvements. Let me quickly unpack that. I'm really not interested in development. I'm interested in sustainable development, which is development that lasts the moment you've left the room. But actually, I'm not even interested in that much. I'm interested in sustainably sustainable development. How do you set up a system whereby people can come together to improve it, and because they've come together to improve it, it lasted? And then a process of renewal whereby new people step into those roles and lead the next stage of development without dropping the baton. In America, in the UK, in the Western world, we live in silos in our healthcare systems. We see change and improvement in terms of discrete projects. And yet anyone who knows anything about these things know that both of those 2 things do not work in any sensible way. They're very expensive, they cause short-term, small incremental changes. They do not cause the longer-term galvanization of people to collaborate for the sake of the population as a whole. So I'm after sustainably sustainable development. How do you produce ongoing renewal, new people from different organisations stepping in to collaborate to improve the whole system of care? And to do that, you require mechanisms that facilitate ongoing inter-organisational learning and coordinated improvements. Okay, so that's mechanisms that bring people together from different organisations appropriate to whatever it is you're discussing, and helping them to learn and improve together. And that's the kind of work I've been working on in West London for the last 15 years. So here I want to say something about generalists, and again I'm going to come back to these in a moment. Success requires that roles are shared, communication is streamlined, relationships are nurtured, and inter-organisational learning and coordinated improvements are the norm. Essentially, the reason why generalists produce a better healthcare system than a specialist-oriented one, as Barbara Starfield shows, is quite obvious in a way. If one generalist can deal with A to Z of the medical dictionary and the mental health dictionary and the social dictionary, compared with 100 of specialists, it's got to be cheaper. Trouble is, who can do that well and deal with all those things? So the question becomes an organisational question. How do you get the insights of specialists appropriate to the person in that consulting room so that they can input those bits of knowledge that they don't know? How do you do this? We're back to an organisational question. Secondly, as a generalist, I don't just deal with A to Z of medical, social, mental health problems. I help people who have large numbers of different problems at the same time make sense of them as a whole. So people don't come in to see me with a problem. They come in with life. And inside that life, there are large numbers of problems from different places. And part of my job as a GP, as a generalist, is to help people make sense of those life stories. There's a guy called John Lorna. Great writer, great thinker. He wrote a book called Narrative-Based Primary Care, and I do recommend you get it and read it. He says that my job as a GP is to help people write better stories. People come in with one story and you help them to rewrite that or rethink that so that they can walk out with a modified story. And he says what you do is you follow the asides. People come in with what they think is acceptable to say to a doctor, or the thing that's in their mind. It may well not be the thing that's bothering them. So John says, follow the asides. So he says, I'm so sorry, doctor, I'm late. I was at the school. Oh, which school were you at? Nothing there. But I've just come yesterday. I was with my neighbour. Oh, tell me about the neighbour. Oh, work is, I went from my work. Tell me about your work. So rather than drill down to the headache that they've come with, you follow the asides, and somewhere inside the asides, something will happen. They will say, I've just come from work, so tell me about work. Oh, God, work! And now you know you've found the place where there is profitable to go to. So that way of consulting, which he calls narrative-based primary care, allows a full breadth of things that is bothering someone to be highlighted, and also for you within a few minutes. This is, when you're skilled at it, it actually takes very little time to do this. It's just like chatting. You can do bang, 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 bang. You drill down to the place that is really mattering, and from that you have a better conversation about the headache, or whatever the presenting problem was. Okay, we'll come back to that. So, I want to go back to these two things and ask you kind of who's in the room, and to what extent these things resonate with you. So firstly, can I just have a show of hands? How many of you actually clinical people? Do you actually see patients? That's about half, okay. And how many of you are public health in the sense of being more concerned with data and populations than with personal people? That may not even describe you, but yep, okay, more. And who hasn't put their hand up? Right, let's hear who you are.
We're medical students.
Okay, well, take the microphone and just tell us what on earth are you doing here?
Well, if we're in primary care and we're worried about the population of all the people we serve, it's interesting to look at
closer to your mouth, so they can...
It's interesting to look at the population level as well as the individual level.
I mean, I thought medical students had much better things to do at 6:30 in the evening. I mean, what are you doing here?
I don't know. Break from studying.
Okay.
Promised food.
Promised food.
Yeah.
Oh. Let's hear who you are.
I'm also a first-year medical student, and I'm very interested
Turn
in...
the volume up a bit, please, just on the...
This is
okay.
turn your volume up.
yeah, I'm a first-year medical student, and I'm very interested in primary care. I'm probably going to also be doing an MPH. and I'm really interested in both, particularly you, because I feel like you have a more global perspective, and also just you know, the intersection of medicine and public health.
So what do you want out of the next, what it is, hour or 3/4 of an hour on this question? What would interest you in that question, or what do you bring to that question?
Well, I guess I have a little bit of experience working in a free clinic and just an urban area, and I thought it was really unique how they managed to bring in like medical doctors, nurses, dentists, as well as social workers and like a nutritionist, and it was pretty much just like a one-stop shop for healthcare, and I thought that was a really interesting model.
Okay, thank you. And there was one other hand. Let's hear who you are. I'm not sure it is actually magnifying. Is it like?
It doesn't. It just picks up the recording.
Oh, sorry, Kurt. I got what you're saying now. Yes.
So my name is Colin Drummond. I'm actually an engineer. I'm in biomedical engineering, and I work with a program at CASE called the Translational Research Program. So I'm interested in how engineering type things can affect care. More recently, I've been working with Department of Anesthesiology on why it is that electronic medical records and clinical decision-making systems can't serve the people they were meant to. And so when I see about the trusted relationships, it's something about crossing the boundary. It's just not happening.
So what made you think you'd come this evening? And what would you like out of the next 3/4 of an hour?
I generally try to go to talks where I may not know much, and it helps me learn.
Right. Okay, but, oh, sorry, no, not you, Alison. In part, what I'm doing there is illustrating what one does as a generalist and as a developer when you're dealing with a community. You highlight the obvious, the public health primary care, and then you say, well, you explore the edges. And it's exploring those edges very often where a lot of fruitful things. So thank you for the three of you for being explored to illustrate the point. Let's hear now from others of you this contention that public health and primary care think differently about health is improved. Let's have a few views on that, please.
I loved your slides. I am not trained in public health or primary care, but I really think that they think similarly. So I actually responded to that sentence by saying, wait a minute, what's similar between them? Because that's what I'm looking for.
And how would you answer that question?
I think it has to do with holes in systems, that a generalist looks at the human body and mind and has responsibility for understanding a lot of interactions. I think public health is the same way. I also think that a good primary care physician is a member, if they are a member of a community themselves, and know that the health, I consider myself a bit of a shaman, so know that the health of the community influences strongly the health of individuals, that a good primary care doctor will be a member of the community and help other people be a member of the community and keep that community healthy, because that's how the individuals are going to stay healthy.
Well, I would of course agree with that. Let's hear another couple of takes on this, this dilemma. Am I right or am I wrong?
If I could just respond to Peter's comment that he thinks that public health and primary care think alike. I think public health and primary care think we think alike, but we really don't. You know, there really are fundamental differences contained in this same brain, because I do both family medicine and public health. But even in those settings, I function differently when I'm in a one-to-one setting than I do when I'm in the public health setting. So I think there are more shared characteristics than there are differences, but that fundamental unit of care issue in family medicine, even if we expand the unit of care to the family rather than the individual, the unit of care is always smaller than the unit of care is for a health department or for someone primarily concerned with population health. So I think there are opportunities to enhance the ways we think alike, but I don't think there's been any systematic effort to help us do that.
But Peter is saying that you can just switch between one and two, one or the other, without any difficulty. So who's right?
Peter started by saying he's trained in neither. So I think he has he has the opportunity of saying maybe they should think more similarly if you look at it without the preconceptions of being trained in either one. That might be, I want to bring some I think there's some opposition, but also some agreement, perhaps.
Yeah.
Bill Donahue, reincarnate everything. Coming from a public health background, I think that I agree with where Scott is coming from, but I think the future, there may be improvements in sight, hopefully in the next 5 to 10 years. I think your slide really resonated with your discussion point about people come in, with a life with lots of problems. We find ourselves often thinking about the fact that you have to help people problem solve, whether it's in the home environment or whatever the situation is, to really often address particularly those most in need that have a whole confluence of problems. These, as we hear from a local person that talks about Stu Greenberg from a local Environmental Health Watch, a local nonprofit, that talks about the compounding disadvantages of poverty and helping folks think through those things and those problems, because it often isn't just that one issue, as you described, that we need to address. But I think the current system doesn't allow for primary care and public health to think alike. The system drives the physician environment, of which they are beholden to, and it prevents the opportunities for very well-meaning folks to find the time or to have the opportunity to have extenders to create that link. I just don't think it's there right now. I hope that it can be built with the way the system is evolving.
Okay, let's build from that. I won't carry this on much too long, but a few other views on this dilemma, please. Kurt.
I think I have a hypothesis that one thing that both public health and primary care do particularly a lot of is iterate, is go back and forth between the parts and the whole. So that when I'm working as a family physician, person comes in, I'm looking at the whole person, and I've got this scanning function, and 3 or 4 issues that could be addressed kind of come to mind, and then I'll narrow down on one, and I'll get a little information on that, and then that'll bring up something else, then I raise my gaze again. So I'm always going between the narrowing down gaze and the going up gaze. And the funding that exists in public health and in healthcare is very focused, very reductionistly focused. It's for very categorical kinds of things. But I think both public health and primary care, their worldview is to scan and then narrow down. So to go back and forth between the parts and the whole.
Who else wants a bite on this one? They think differently. Anyone?
If I could just say one more thing. I don't mean to keep others from talking, but I just came back from St. Louis, where I was at a meeting working with Ross Brownson, who's championed a curriculum in evidence-based public health. This curriculum in evidence-based public health really demonstrates how differently public health and medicine work, because evidence-based medicine, the principles of both are the same, but the teaching examples are completely different, and what we do with the evidence-based public health is completely different than what we do with the evidence-based medicine. And I came out of there really convinced that one of the ways to make this connection is to jointly teach primary care doctors and public health people in this evidence-based public health curriculum, but expand the evidence-based medicine piece of it, because I know I looked at the evidence-based public health differently from the eyes of a physician and public health person, and I know that the public health people would look at evidence-based medicine differently and each inform the other group if we did a joint training using that framework to help doctors better understand what we do in public health, and public health people understand better how doctors make decisions.
Okay, go ahead.
This, at the risk of saying something totally irrelevant, but what you just said resonated with me, because when we've studied the reason for failure of the usage of electronic medical records, it's usually because people haven't taken a long-term approach. And you talked about living. So when the clinicians are heavily involved in the design, if they're involved, over a period of 6 years is when you finally get to the effectiveness of the records. And so the challenge is, you talk about those organization and ideological boundaries. You know, you can get the engineers and the clinicians there eventually, but if you don't have this partnership and you don't have a long-term view, it usually fails. Just kind of a parallel.
Okay. Anyone else want to, the MPH people want to say anything about this? Okay. In England, public health deals with populations. General practitioners deal with individual patients. And there's this uneasy recognition that we need each other and want each other and like each other, but we don't have any easy way to work together on those things. So, for example, public health people will run walks programs for people who are overweight. They will do joint strategic needs assessment of what the population needs, and both of those are incredibly helpful to me. So I know what's going on in the population and I can refer my patients to them. But they are different from what I'm doing. Now, of course, there are places where the role is more blurred and practitioners who are more or less in tune with the other discipline, but the training, the location, the orientation, the outputs, the expectations are sufficiently different in England to make collaboration very easy. So what I put here, when that is the case, when you don't understand people very well, or you're not inside their training, or you can't quite work out what they can contribute, you need long-term partnerships for health improvement. It requires long-term opportunities to appreciate what each can contribute. Now, I'm going to show in a little while some other things other than public health, but this is not just a public health issue. The same thing about surgeons, cardiologists, social care, the voluntary sector. In all of those instances, I know I need them, but I don't understand their worlds. And for me to work creatively with them is a very difficult thing because I haven't got any easy inroads into them. That's the issue that I've been trying to work with over the last 10 or so years. But even having opportunities to appreciate what each can offer isn't enough. In order to feel that you're really on the same side as people and working with them and thinking cleverly about how you can improve cost and quality, which usually means reducing cost and increasing quality, but not always, you require shared projects, because it's in the shared projects do you move from appreciating that they may be useful or seeing from a distance that they are useful and actually feeling at a deeper level that you are working with them as a team. So my contention is that a healthy healthcare system requires a sequence of shared projects that builds trusted relationships across the public health primary care divide and also with other disciplines. This requires a shared developmental space. Now, if you're only talking about public health and primary care, actually probably you can get by without having a major shared developmental space. You can have two departments side by side and you can work on each other's projects. So you can continue that. But the moment you start opening the collaboration up to other groups, voluntary sector, specialists, social care, you're starting to get too many people around to be able to make these ad hoc arrangements, and you require a shared development space. That is my contention. A community or a geographical area. Okay, put that one on hold for a moment, unless anyone wants one last comment on it. Okay. So, this is a bit about the generalist. I'm sitting there with the world coming to me, having to deal with the A to Z of these various dictionaries and deal with the complex interactions of various things from people. There are too many things for me to understand, too many priorities to pursue, too many people to know. Success requires me, in my general practice, to work with other general practitioners and other people, to share those roles, to streamline communications and nurture relationships, so that we learn and coordinate our improvements across organisations. So this is a different take on the public health primary care need to collaborate. This is my need to collaborate for my own sanity. So for these to happen, for me not to just be overwhelmed with the world as it comes to me, I need mechanisms that facilitate ongoing inter-organisational learning and coordinated improvements inside those geographical areas that I described earlier. So this is what you have. This is me, or you, or anyone involved in healthcare, overladen by the rain of demands and pressures that are the reality of day-to-day life. Trapped by the system. And you have an option to go back into detail and panic, which I very want to do much of the time, or take a risk and move into a learning space where you meet with people from different backgrounds in order to think about collaborative solutions. And not just one of these places, you need to have these places all over the place, and these need to be connected. I see that as the challenge that we face in order to escape from everyone trying to do everything in silos to being able to interconnect multiple development places. The aim is not just to make me better able at juggling all the balls I have to do, but to do it with other people. So you get interactive juggling, where you're able to work with people creatively across organizational boundaries to improve the leadership of the system. Just before I move on from this, I just want to point out this one here, which is the unspokens, the things you're not allowed to say. That box is always hovering and often not opened. You actually very often can't even open it in the early stages until these groups become more mature, because they are often dangerous things to say that people don't like you to hear, like, for example, the quality isn't very good. Go.
So just two local examples that, for me, you've pointed out in these slides. One is the HIP-C initiative that Terry has been running, that's really getting people from all the different communities in the county looking together at what the healthcare, or not healthcare, what the health needs are of their communities, and then a process for keeping people at the table, prioritizing, looking at how they can work together. And then in the healthcare sector, the Better Health Greater Cleveland, which has healthcare systems that mostly spend their time and energy competing, that now have been at the table for a number of years, looking at the quality data, sharing and looking together at how they can improve. And so this shared space, this little island that you have, it strikes me that those are two local examples of what's important there, and that you start developing trust and realizing that you can't solve the whole thing yourself, and asking who else needs to be at the table. And it takes time, it takes years, but and it can fall apart, but that is the kind of space where something good could happen.
Kurt, you've raised there another issue that I'm very glad you raised, because it reminds me of something that was said by Richard Elmore in 1966 in a paper he called Backwards Mapping. If you want the system, he was an advisor to the Washington government. If you want a system to work, you need two things, he would maintain. You need strategic coalitions, the like of which you're describing in these groups that are beavering away for years to improve things, and you need street-level discretion. That is, you need people at the most peripheral point with the elbow room to be creative, and you need both. And he describes this in a paper called Backwards Mapping, because he says, start planning, not centrally, but at the most peripheral place where people are, and say, what do you want to happen there? Let's say you want receptionists and GP surgeries to be nice to people. So you then say, step one back, and what environment will make it more likely that they will do that? And you put that in place, and then you step one further back and say, what environment will support this person, to support that person, to support that person, to do what they want at the most peripheral point. And what you want at the most peripheral point is for people to be creative, so that when the person with that street-level discretion, so that when they are confronted by a patient who asks them a question, they don't have to go and ask their boss, but they themselves have degrees of freedom where they're able to answer those questions really cleverly for people. Scott.
I did just want to point out that both of the examples Kurt gives, which are excellent examples of exactly this kind of thing happening, had systems incentives that allowed them to occur. And even if the systems incentives just allowed us to do what we wanted to do but couldn't do before, without those systems incentives, it couldn't have happened.
Yes.
You know, there's a huge move in public health towards this community improvement planning. It's a requirement for accreditation, which is a new thing to local health departments. So this is a systems incentive that brought us together in this process. The funding for Better Health Greater Cleveland is the incentive that brought them to the project, and it has evolved in very wonderful ways. But again, without those systems incentives, we wouldn't have been able to accomplish those things, and that has to do with that shared developmental space that you're talking about. The systems incentive provides the space in which we can interact in a functional way, and that's the one word that I haven't seen there that is implied, but I would suggest be primary. There has to be a functional interaction that hopefully is an ongoing function and not a temporary function.
The only thing along those lines is I really think, from my experience with this health improvement planning process, is there was an incentive to bring us together to work across sectors. But I think the more I'm looking at this, that's the easy part. I think that sustaining it, as you've said, it's going to get tough as we bring together more people with different priorities and different backgrounds, and I think there may be politics and other things that become involved in the process. It's actually going to get very difficult. Yeah. And so I have concerns about the ability to break through as we move forward to really choose a few things to concentrate on to make a difference. We have to. I think we realize we have to. Yeah. But I think it's going to get very difficult before, and we're going to have a little luck, I think, in the process to make it happen and be as effective as we all hope it will be.
Who am I? I'm a psychiatrist. I've been out in the community for several decades. But I also was the medical director for the Sexually Transmitted Disease Program prior to becoming a psychiatrist in the city of Cleveland. And I publish in the area of the effect of sexually transmitted diseases on human evolution. And what I've theorized is that sexually transmitted diseases cause the family, reducing partners, improving bonding, selecting for bonding. So I've been out in the periphery. I was just recounting that I dared to, thinking of my patients rarely had a primary doctor that they could go to frequently or anything. So I'm prescribing vitamin D and vitamins and not going too far into areas that I'm not really trained in. You know, I know my boundaries. So now what's happened is I'm coming back to the medical school where I graduated from, finding a whole new set of people, all kinds of different programs. So I'm coming from the periphery, having been creative, and so what do I do? Now I come to conferences and I'm meeting people, but so how does the periphery affect the center? Right. Which, if Thomas Kuhn and medical science historians, it's very difficult to change the standing hierarchy or integrate it.
What I'm talking about is how you set up a system that does that. Now, how I would advise you to do it in a system that doesn't do that would be a very different piece of advice from what the system will be. So bear with me on this way of thinking, because I think it becomes obvious how people on the periphery not only can get involved but are welcomed as part of the solution. That is not the case at the moment because everything is so fractured and uncoordinated. And I'm suggesting an unfractured, coordinated and developmental approach which welcomes people from the periphery. So if I move on from there, some of you may have seen Laura Nazir, who was speaking here recently. She would have described to you the Southall Initiative for Integrated Care, and I'm going to just briefly summarize that using this model. Here it is. Southall is a really deprived part of Ealing. Ealing is in the centre of West London, and it's got 26 practices in it, and they were deemed to be poorly performing practices by various people. The criteria were made externally. And we worked, a facilitation team worked with them and the community groups and public health and specialists to say what are the priorities around here. And we got them in large groups to do those kind of things. And then they came up with 4 big areas that required long-term collaboration across organisational boundaries. And they were diabetes, high Asian population, high number of diabetics. That involves working with specialist diabetologists. Mental health, anxiety and depression in people who present with anxiety and depression in a different way than you may expect from an Anglo-Saxon. Dementia, a growing problem that particularly impacts on social care, and working with public health, patient advocacy. Receptionists and other people were prime position to be able to advocate for patients, and expert patients were in a prime position to advocate as expert patients, but they weren't being used. The various meetings that brought these people, large numbers of people together, arrived at the conclusion that those 4 things should be tackled in the next year, and we divvied up those 26 divvied, is that an American word? We divided the practices into 4 groups, which we created as clusters of about 25,000 population. And we got them, those clusters of practices, to work with the organisations of relevance, that's social care, acute care diabetes, public health, and the last one, mental health, and to look at the issues about communication and collaboration and come up with a project. And they led that project, and it caused a bushfire. Not only did these 26 practices that were apologetically sidelined and not really engaged in development at all, they were suddenly engaged on the front foot, making things happen. These people are ordinarily not the people who come along to meetings. The project they developed were the kind of projects that had been needed for such a long time that within a year they were snatched out of their hands and taken on board by the major organisations to lead from a central place. So that is the power of this kind of collaborative thing to create activities. So I'm making a leap now from there, I think this is the right thing to do, to what we're doing now, building from that learning. And for those of you who've been leading change before you will know that I'm editing out a good chunk of mess. What's happening now about what we're doing is definitely not in any way linear from what it did before. In many respects, the Southall initiative that was hugely successful in the ways I've expressed was actually stopped. It was in a way too noisy for the new authorities, and it was prematurely stopped, even though it cost virtually no money and was causing great things, on various pretexts, shall we say, or various rather unspoken ideas. And I would say because it was making more noise and more activity than you expect from a health service that is used to siloed projects. And a couple of years later, all the principles, or many of the principles that were piloted there, are now finding their way in to established policy. But it was not a simple link, right? So you can ask me about that later if you want. Right, so general practices throughout Ealing. Remember, we're talking about 350,000 people, 79 general practices, clustered into geographical areas that are small enough to feel you belong and large enough to have political influence. Local health communities, or health networks, or university, I'll come back to this term later, must enable multiple collaborations. So we're talking about groupings of practices that are small enough for people to feel that they belong inside them and large enough to have political clout. And in different points of history, in different parts of the world, those sizes may be different, but it probably does need those kind of things. Within an area, there's horizontal integration, collaboration between patients, community services, voluntary groups, social care, public health. Out of area or vertical integration, acute and mental health trusts. Trust is our term for like an authority, like a hospital is a trust. Universities, professional bodies. So you align these geographical areas of 30 to 50,000 population with extended primary care teams. Now in England at the moment, the general practice has its core team of practice managers and practice nurses, and then there is another function called the community services that has district nurses, community matrons, podiatrists and so on, employed by different authority. We're proposing, or we're trying to make happen, where am I here? I need to look here. The development of extended primary care teams that span those boundaries. So the community matrons and the district nurses will be attached to the practices. Intermediate tier clinics and community hospitals. Okay, let me paint the scenario of diabetes for you. Until a couple of years ago, all diabetes pretty much were dealt with in the hospital, and some practices did diabetes clinics, but it was like two parallel systems. We've now got, over the last 2 years, as a result of this work, the situation of the hospitals divesting, transferring all of their patients to Tier 1 and Tier 2 clinics. Excuse me. Tier 1 clinic will be a general practice-led diabetes clinic. Pretty much all diabetes should be managed in these clinics, but a small number will require specialist input, and they will go for an opinion, for a review, to a Tier 2 clinic that will be based in these groupings of 30 to 50,000 people. Hospital care will be reserved for very specific, very brittle people who require multiple consultant input, pregnant women and children. We've got data that shows that there's a dramatic alteration as a result of this work into the community clinics. So we have those relationships developed between Tier 1 and 2, partly by the proximity, but also by telephone contact. They are supposed to phone each other up on a regular basis to advise on clinical management in real time.
Can I ask a question?
Yep.
So can you describe the relationship, fiduciary or otherwise, between the hospitals and these primary care teams and these clinics? Are they all governmental? Is it a complete governmental system, or are these?
Yes. For the purposes of today's conversation, you could argue that they are, general practice refers to hospital care and it's all part of the NHS, right? And you hand over the patient. Actually, it's a lot more complicated, and having the financial arrangement is quite complicated, and actually what I just said is not true. But for the purposes of today's conversation, you can see it that way.
So trying to read Terry's mind, he's thinking, that sounds great, that sounds logical, that sounds organized, but following the dollars, how the heck could we possibly do that here with the fragmented payment that we have?
Hospital coughing up a bunch of patients to some other practice. I just couldn't imagine that happening.
And while we're interrupting, what's a community matron?
Community matron. Okay. A community matron is a specially trained nurse in case management who deals with people who are high users of the hospital system.
That would never be what we would call them here.
Okay, well, leaving aside the niceties of language, I probably need to say a little bit more about the financial arrangements to satisfy your question. The hospitals are paid on a salary basis for the work they do, and they do what they're told to do by their hospital. They are able to do private practice on the side, by which they can boost their income considerably. Leave that part out for a moment, it's rather irrelevant to today's conversation. General practice is paid like a corner shop. It's a small enterprise. It can have 2,000 patients, or it can have 10,000, or even 20 would be a very large practice. Now, those practices are paid on a per capita basis. So if you have 2,000 patients, you get 2,000 hits, 20,000, you get 20,000 hits. But there are other mechanisms too, including whether you achieve certain quality criteria, let's say control of diabetes, sugar, or whether or not you do minor surgery. So there are a number of other payments as well that go into the pot. Now, the next complication that is relevant to your question is that commissioning. Who decides where big contracts are placed? And that was the health authority called the Primary Care Trust. That is now in the process of being transferred over to groupings of general practices. So where once you had a primary care trust that was like a health authority, coterminous with the borough, which is the social service, and the local authority, coterminous usually, not always usually. Now you've got alliances of general practices stepping into that same geographical area to lead commissioning. Go on.
So that sounds a little bit like the blended payment that we're supposedly moving toward, where you get paid just for taking responsibility for a population of people, plus payment for other specific services, plus some payment for quality. It sounds like the accountable care organization that we're supposedly moving toward. What's different is the way we're approaching accountable care organizations, which is not geographically, it's not taking care, it's not being accountable for the care of a geographic community. It's allowing you to take responsibility for a certain group of people that have a certain kind of insurance or that have certain other characteristics. So we're trying to get there, but we've taken a right turn that makes it hard to do, I think, get the advantages you're talking about.
And incentives for hospitals remain putting patients in the hospitals and doing procedures. There are efforts to move away from that, but the efforts often my fear is that the efforts may penalize primary care providers as we're trying to implement these kind of systems long before they'll have any impact on the hospital systems.
Yes, there's evidence of that happening in England as well. So the GP commissioners now, who've only just stepping, they haven't even stepped, they're stepping into that place over the last year or so, that's what's been going on, has meant that a number of hospitals are being challenged to pretty much close, actually, because there are too many hospitals in West London. It's very expensive care, and they're taking, they're not sharing the care with general practice, and so they are having their budgets taken away unless they play ball with this kind of thing. So there is a lever that we have that you don't have. Let's continue with the theme, because whilst this is all part of the world I'm immersed in, if I kind of say it all, it'll confuse me, let alone you. And what I'm trying to get at is these processes of collaboration which are essential, because you can alter the structures and you can alter who calls the shots, but if you don't alter the process of engagement and collaboration, it still won't work. And that's what my minds are focused on in this talk. So inside this groupings of 50,000 populations, I'm now looking at number 2. You create lead practices for diabetes, another one lead for public health engagement, another one for academic and research, another one for children, whatever, so that those practices can preferentially, for that period of time, let's say 1 or 2 years, become the people to establish relationships with those people across those organizational boundaries, and as a proxy, befriend them across the whole patch. I've used the term shared leadership teams here. This is a term from the organizational and leadership literature about people of different disciplines who lead in the sense of making sense of, helping people to coordinate and move together across multiple organizations. And an annual cycles of inter-organisational collaborative inquiry and coordinated improvement. So throughout the year, there need to be a series of scheduled events that people, including outliers, and especially outliers, can pitch up, contribute to the shaping of a project, and step into the place of applying for the role of leading this or that or the other for that particular period of time. Ongoing data to illuminate outcomes and improvements. Now, one of the failings of the NHS, and probably most countries, I think, is this desire to use data to hurt people. You gather data routinely about what's going on, and you use it to beat people over the head or performance manage them or to take away their money or whatever. So people are scared of data. And data are very often produced, gathered in a bad way, they're presented in a bad way. So how about doing something different? Is that we routinely gather data well because it helps us to improve. And instead of waiting 2 years after a research project has been finished to work out whether it was any use, how about producing this every month to be able to show the people who are engaged in a service improvement project that actually they're making a difference? And how about putting that on the wall so that you can see January, February, March, April, May, what they're doing in terms of improvement measures. Now, improvement measures is slightly different from an outcome measure. Improvement measure, as I understand it, means kind of behavior change. So, for example, in the diabetes example I gave to you, every time a GP or a practice nurse rang up a diabetes specialist nurse for advice rather than referred, that would be an improvement measure because that's what we want to happen. Every time a patient is transferred from the hospital tier 3 to tier 1 general practice or tier 2, this local health community clinic, that would be a behavior change. So measure that too, value it. You don't have to pay for it. You stick it on a chart and show everyone what's going on, and you compare all the health networks and have them side by side, and you name and shame people. A different approach to motivation. A more collaborative and humorous way. Actually, I was at a meeting just a couple of weeks ago, and coincidentally, there were 2 people in this grouping who hadn't engaged in this kind of stuff. And it was just easy to just friendly, I think it was friendly anyway, sort of name them as people who hadn't engaged. I hope I pulled it off, but anyway, sort of, you know, Dr. X and Dr. Y, who, by the way, I happen to notice haven't come along to the meetings. You can get away with it provided you're consistently inviting people to the meetings and consistently working in learning mode as opposed to punitive mode. Now, in a different kind of environment, that kind of accusation will be dealt with in a very defensive kind of manner. In this case, it wasn't, at least I don't think it was. Okay, just a bit of context. I'm moving into more specifics now from the more philosophical and, yeah, Peter.
Can I just ask you that continuous quality improvement or total quality management? Because you're talking about the concepts there around learning and cycling and using data for improvement.
I do use those terms very, very frequently. The reason why I'm not using it at the moment, maybe just because today is Thursday, but also it comes with a load of baggage about these things being very discrete, controlled projects. Same with translational research. We've got an organisation that has funds for translational research in West London, and they've got this very linear, controlling approach to change where you research it over here and you stick it in there as a total quality improvement kind of language. Whereas I'm talking about a much more complex engagement of large numbers of people about what are the emerging issues, and out of that, developing a project. Essentially, if you're talking to the right people, it's the same thing.
But I actually thought that was the answer, not that it was Thursday. That in actual fact you felt some baggage associated with those words. But
I use the term quite a lot, actually,
okay,
so
right.
it's a bit of both.
I'll go back to my Thursday explanation.
Okay, so Ealing, so Houses of Parliament here, Big Ben, Heathrow Airport here, and there's 2 million people in between. In 8 of these health authorities were called primary care trusts or boroughs, now called clinical commissioning groups. There's inner and outer subclusters. That's only relevant to something I'm going to tell you in a minute. So there's 4 groupings in the inner area closer to the centre of London and 4 in the outer. Large numbers of hospitals. Too many hospitals. Large numbers. Ealing is in the middle, actually. It's the outer subcluster, but actually, if you look at it, it's bang in the middle. It's got about 350,000 population, 79 general practices, which is probably too many, actually, a lot of single-handed. 7 health networks of 50,000 population. The figures are rather convenient, or maybe I've massaged them a little bit. Approximately, that's right. I've mentioned the Southall initiative already. Now, Southall, for example, has got a quarter the size of Ealing, but it's got 1/3 of the diabetics, reflecting its high Asian population. And they are particularly underserved because of things like they don't speak English and those other issues. I'm not talking about that today, but it's kind of part of the mix that we deal with. And the integrated care pilot that was for 1 year happening in the 4 inner boroughs, and we've just now adopted in Ealing as well. And that integrated care pilot is what I'm going to tell you about now. Oh, not quite now. Little bit. I'm going to jump through this a little bit more quickly. Inside the 7 health networks, we have appointed 2 GPs, not always GPs, sometimes they're nurses or managers, who facilitate twice monthly workshops at which the people inside these networks, 10 to 20 practices, create care plans for patients who need them. So particularly people with diabetes and who are the elderly. So those co-chairs facilitate this meeting of, let's say, a diabetes consultant, let's say 10 practices, let's say 6 care plans, which are uncommonly complicated. So here you've got a shared project, a 3-hour meeting once a month or twice a month, where people from these different organisations are creating a care plan for a patient, and in the doing of it, developing relationships and understanding what they're doing. At the same time as that's going on a monthly basis, over here we're developing the Tier 2 diabetes clinic that I mentioned a couple of minutes ago. So they're developing relationships with these people that then we put to good use over here. Shared leadership teams facilitate whole system improvement projects. Now there's a fund, an innovation fund that these health networks can apply for, and they put in bids that they work out around that table. So then that starts becoming a shared project moving forward, and that will go into this annual cycle of, you know, a rapid appraisal. What is the project? Bashing it around a little bit. A rapid appraisal. What are the improvement measures that we need at different times of year? And then everyone jumps at the same time to make the same changes inside the diabetes world, inside the social care world, inside general practice world in the same few months, with weekly or monthly measures about how they've improved things, to feedback at the next stakeholder conference about what everyone's doing. So you've embedded inside this an annual cycle of scheduled events that are learning oriented to move total quality improvement stuff along. Shared leadership teams. I've mentioned this before. I'll just mention it again because it's such an important concept. Boundary spanners are well known in the literature as people who got feet in more than one world and they help the worlds to collaborate with each other. God, it's a rough job. You know, you just get shot at from both sides, and how about developing shared leadership teams over those things? So you don't require on heroic individuals to get shot in these things, but you create across those boundaries teams of people, and you invest in those teams through things like training and residential workshops and resources so that they can do that job well as shared leadership teams. And then I've mentioned this, reports from routinely gathered data. So we're working on how you gather data about hospital episodes, about patient satisfaction, about a number of people who attend various kind of clinics, feeding back to these health networks in an amalgamated form on a regular monthly basis so they can see the impact of what they're doing. Now think of the power of this. Here you've got, actually we think there's a problem with, let's say, elderly people who are alone being admitted in the middle of the night, or people who are dying at home dying in the wrong place because of poor communication. Let's say the group identifies this as a serious issue. They put inside a project, let's say it is having the people's telephone numbers in the middle of the night, or let's say it's having a training program or something else, or let's say it's targeted intervention. It doesn't matter what it is, but they've decided on something. Well, you've got the mechanism on a monthly basis straight away to work out their effect. Think how powerful that could be. We haven't cracked it yet, but we're very, very close. I need to speed up a little bit. This is just talking about the protected learning space. Oh, it's so nice to walk into a place with friends and talk about interesting things with people to challenge you, but do it nicely, compared with the hurly-burly of everyday life. People love these things, and they love talking about their work and their patients, and it's like the grit in the oyster. You know, they talk about care plans, but it's the relationships that are being developed that is the magic of this, and the mutual understanding and respect that develops after a few meetings. So my intention is that these very quickly move on from this place where we look at diabetes and elderly to become more of a postgraduate education club, where you have it subsected by different times. We'll have different meetings going on in different rooms and people feeding back what's going on as a kind of a hubbub of learning life inside that health network, as well as the continued care plans. This is a busy slide, but this is the integrated care pilot. It's not as complicated as it may look. I'm going to just talk you through it. There's a registry of patients who have got, I'll just choose diabetes, but we're focusing on diabetes and elderly. I expect within 6 months we'll be focusing on other things as well, like dementia and so on, and respiratory conditions, but that doesn't matter. I'll just use diabetes and just read that as anything that's long-term. Registry. You stratify risk. Who of these people need to be seen more? And you develop care plans for them. And those care plans are produced inside the practices, not at these health network meetings, by practice nurses probably. in order to understand in breadth what people's problems are, their intentions about dying, whether they've got wills, who to call in an emergency, those kind of things that really help you in a crisis. So produce care plans. And there's sort of good practice standards. Okay, then some of these are particularly, some of these care plans are particularly illustrative. They're particularly full of learning, or they're particularly complex. And those are the ones you bring to these monthly meetings I'm talking about, the workshops, where you debate the issues with other colleagues and with people from other organisations. So whilst it says GP, practice nurse and so on, that means whoever enters that space. Sorry, I've jumped from here. Sorry, this is people doing it in practice. This is the workshop here. And then there's a performance review every 3 months of that same group about whether it's doing things that justify its funding. Now, I need to tell you that this is not cheap. The people who go there to the workshops, the monthly workshops, are paid. They're backfilled. And that is a very expensive thing. So there's a business model. And the business model says that to continue funding this kind of activity, you have to save 1 admission per practice per month. Right? That's an awful lot of admissions. But if we're right, that this kind of collaborative, co-evolving and appreciative way of doing things is so clever at producing clever solutions, it will do that and more besides. You can see the point about evaluation, ongoing evaluation, because I mean, we're facing, like you, everywhere else, is huge. There's a £2 billion redundancy bill for the NHS in the UK because of the crisis in the Western world of money, right? So you can't keep something going on that is expensive unless it demonstrates that it saves money. So I'm jumping to this one to show, well, it does. This is the participating practices in the inner sector that do this for 1 year. And non-elective medical admissions went down in that year compared with those who are not participating that went up considerably. And whether or not this is right or wrong, if it gets sustained, you have to carry on doing this kind of analysis to argue the case that collaborative, complex collaborations is cost effective. I'm going to just jump back because I'm running out of time. This annual cycle, I just want to point out to you that if you want large numbers of people from all over the place to collaborate, you have to have a predictable, you have to understand the system of engagement. So you can say, in November, we'll feedback what happened in that year, but we'll also identify new priorities, and we'll form leadership teams to meet those forward, and they'll do rapid appraisals, and we'll train everyone in the spring when people are really not feeling very good after Christmas, and they don't want to do thinking, but they can get down and do their jobs and gather data. And they can be working on these so that by April, when you know how much money you've got for the coming year, and it was less than you expected, to shape these new projects and to showcase, the previous year's projects. So from those shaping of new projects by July, you've taken those projects up into a really tight developmental plans for different organisations. So the diabetes hospital will have a plan, so will the practice have a plan, so will the community service have a plan, and they will all do these things in the same few months between September and November at the same time with monthly or weekly measures to show they're improving, to feedback the conclusions, and you started the cycle again. That's the plan. And that's what worked in Southall to produce not only dramatic improvements, but enjoying work. People just love, they can see the coherence, they can see they're not alone. So I'm just going to finish on this slide. This is such a different way of operating than the one-to-one. We are trained as clinicians in the one-to-one. Managers are trained in projects. This is a completely different way of thinking about whole community, whole system collaboration in annual cycles of quality improvement. And the things you need to do this are not on the medical school or the public health curriculum, and they need to be. So we need practitioners and managers who can conceptualize, evaluate and lead whole systems of care, learning organizations, empowered communities, and multiple interconnected improvement projects. They need to be able to do that. We need to be training people to do that. We need networks of high-performing shared leadership teams. Not just one or two, but a whole industry, a lattice of these teams. And the role can be moved on. So every couple of years or a year, you change them and can become part of people's career paths. We want generalists who see health as narrative unity as well as a collection of diseases. That's that John Lorna bit that I mentioned earlier. People see their health not merely as a cluster of diseases, but the coherence in their whole life story, which having a disease really gets in the way of enjoying it. But it is not the thing. It is the sense of coherence. I am the lead actor in the feature film that is my life, and I am the co-actor in the feature films of other people's lives. That is unique to me, but I am, and health is bound up inside that, and when I have a sickness, a disease, it gets in the way of that coherence. Case management and shared care for people with long-term conditions, I've said that many times. Researchers able to crystallize meaning from multiple methods inquiries. Just a word on that. Researchers among you are probably familiar with the term triangulation of data. It comes from that trigonometry thing about working out the height of a mountain. You see it from 3 different places and you work out that's the height of the mountain. Well, that assumes that the height of the mountain is always there in a predictable kind of way. In this kind of work, when you come from one's perspective or another perspective, you see things differently, you prioritize differently. It's the leg of the elephant. You know, that elephant thing. So it's not as though you're looking for that discrete thing. You're trying to make sense of large numbers of different inputs. And that's what researchers in this territory need to do. They need to be able to facilitate consensus, understanding, meaning inside whole stories. And that's called crystallization of meaning from different paradigms of inquiry, or multi-methods research will be a thin version of that. And learning between case study sites. And this is where I'm hoping that you in Cleveland could join us in London and other places in the world to set up a set of international case studies that are looking at these kind of things to post papers. So for example, there's places in Canada, there's a couple of places in America, and where I said, this is a journal, London Journal of Primary Care that I run, which is the 3 London RCGP faculties pooling money to make it work. It's now gone web-based only, and it looks at integrated care and tricky, complex stuff. And it attracts some quite neat authors, and we rather ask them to write for us rather than wait till they come and offer their services. So I'm asking you to come and get involved with this. So you could, for example, if you want to engage in this, write something about what you're doing inside the journal, then link it to your website. And when new things happen that illuminated your approach to integrated care, you could relink them, or you could post them on our website or your website, or if you get published in the New England Journal of Medicine or somewhere else, you can put a link in there so you're building up a repository of papers that illuminate how you deal with this incredibly complex stuff in different contexts. And then, of course, there'll be other sites doing the same kind of thing, so we'll be able to share insights across those places, and I hope you might warm to that. I better stop. We've done the questions on the way, haven't we? Yes, go on, Peter.
So I also think narrative is a key bridge between the primary and the public, because narrative, when you were using the term narrative unity and the generalist, I was not sure whether you were talking about the narrative unity of an individual or the narrative unity of a community, because the stories that individual tells are part of the community story. And in fact, it's interesting because I work in Cleveland and Toronto, and part of the narrative unity story of Toronto is narrative diversity. In other words, it's a community. But I do think that the interface between the narratives of individual lives and the integration that creates, it maps on a community. I would say to think of researchers as crystallizing meaning That's a new one for me, because I think the average researcher does about everything they can to whatever the opposite is, dissolve meaning, put it into a solution without a solution, suspension.
Well, that's right, which is why we need participatory research.
Yeah,
You know,
it's a different kind of
participatory has to be
researcher,
the new
yeah.
paradigm for primary care research. Any other last points or questions, or was it useful of any kind, or?
Could you comment on primary prevention? How
Sorry,
to
can you
promote
say that again?
primary prevention?
The question again, so could we?
Primary prevention?
Sorry, what about?
In public health?
I
Or
didn't hear the first couple of words. What about primary prevention?
Comment on.
Oh, comment. Sorry, it was that was the word I didn't hear. Right. When a GP is asked to do that kind of thing and there isn't stacks of money behind it, it doesn't happen because you're overwhelmed. But supposing out of this collaborative stuff that's going on, I don't need to show you, it's time to go. People say, look, actually, this is a real issue. Primary prevention of, let's say, child abuse, right? Well, actually, everyone, you can't, it's too big to do on your own. You just like, it's just enormous and overwhelming and emotional. But you get this group of practices dealing with it together. You've got public health leadership. You've got some resources from over here, some other teams of people thinking through so how you go about it. You've got the mentorship over here. You can do it. You can do those really, really hard things in a collaborative, which you just can't on your own. You just burn yourself out trying to do those really tricky things that nobody else is doing.
That public health is doing.
Well, public health is doing some of it, isn't it?
That we're endeavoring to do.
Yeah, be careful for anyone to say they're doing all of it. I mean, when I was in Liverpool, I know that I don't know why I stuck on child abuse, but you know, I know there were times when I saw it coming and just had to put the blocks, and I could not deal with another disclosure of incest survivor, you know? And if you read Bagley and King, like 1 in 4 of girls are sexually abused and 1 in 8 of boys. Now, that's not a little problem, is it? That's like another version of normality. That's just an impossibly large thing. You can't begin to tackle something of such huge importance on your own. So this, I mean, I don't know why. Let's choose something else that's a little bit less inflammatory. Primary prevention of smoking.
Of diabetes.
Oh, diabetes.
Yeah, obesity. I mean, it did occur to me as you were going through the example that it's an example of the difference between primary care and public health, because the public health example would have been more oriented likely to primary prevention of obesity rather than improving care for diabetics, which would be a secondary or tertiary prevention approach.
So in my practice, I would firstly need the whole area to work out what they meant by primary prevention of diabetes, and then I would need some other people to go away and give me the tools to do it, and I need some places to refer stuff to. And you can do that when you're working with, you know, 100 people. You cannot do it when you're just working on your own. Well, you can try, but you just kill yourself.
So I have a lot of students that come to me that want to work on policy, and I think it's because you see, as you're getting training to take care of individual patients, that you're doing that within a system that's dysfunctional, and you want to help improve the larger system. I think what Paul's showing us here is one path to working on policy that involves working at the local level, keeping your eye on the larger levels, recognizing that you can only yourself or even with your small group work on one part of the problem, but that raising your gaze and looking at who are the other people that have different aspects of that, getting people together, working together on the problem, presenting them with the information that they can use to identify, to refine their understanding of the problem, doing, as Peter says, a new kind of research, a different kind of research that's about making sense together and just incrementally working on small parts while keeping the whole in mind. That's what you're showing us a pathway for. So thank you very much for coming here.
You're welcome. Pleasure.